So, good evening, everyone. I welcome you all to this wonderful evening. The charm of this evening is that we are going to install the Cameroon chapter of ISMSICS, International Society of Manual Small Incision Cataract Surgeons. Cameroon is a country which is there in Central Africa, and we will hear about it more from our colleagues very soon. So, this is ISMSICS core team. We have with us Dr. Amulya Sahu sir, who is founder chairman of ISMSICS. He was the past president of Bombay Ophthalmological Society and is a nationally and internationally acclaimed cataract surgeon who has introduced 2 SICS technique. Dr. Sahu is the founder chairman of Sahu Eye Groups of Hospital in Mumbai. Over to you, sir, for a few words of wisdom. Sahu sir, you are muted. Can you please unmute?
Thank you, Aarti. And we welcome our guests from Cameroon. And Africa was, when I was trying to reach out to them, I will find them they are slow. But when I heard about, you were talking about Cameroon, how our Dr. Manga and other people, they got this chapter installed. That means they have started moving fast. It's really a pleasure to know that. So I expect we have opened a lot of chapters in Africa. We want to open more chapters also there. But slowly we will evolve a mechanism how we can share our experience with them and see them that they do the surgery, there's a routine surgery there. Because this FECO and the machine-driven things, something which I think African economy it may be a little bit not so welcome. Let those who can afford go for it, but basic thing they should learn, all of them should learn MSICS, because there we are giving result comparative to FECO, if not better. And this is what I wish, and it's a wonderful welcoming them. Thank you.
Thank you so much, sir. Next, I would like to invite Dr. Jagannath Boramani, sir, who is Executive Chairman of ISMSICS. He has pioneered and popularized small incision cataract surgery under topical anesthesia. Recipient of multiple awards, Dr. Boramani is well known for his X-chopper for closed chamber manual phaco-fragmentation and customized incision cataract surgery. Over to you, Boramani, sir.
Yeah, thank you, Dr. Aarti. I welcome all our office bearers and the members of Cameroon chapter of ISMSICS. SICS is a really wonderful technique, and we are spreading our wings all over the world. So I welcome the office bearers. Dr. Aarti, should I introduce ISMSICS here only?
Yes, sir.
Yeah. I just want everyone to go through the journey of ISMSICS through a video. Can you see my screen?
Yes, sir. Yeah. Perfect.
Welcome to International Society of Manual Small Incision Cataract Surgeons. Scleral tunnel incision is a secure incision. There are newer advancements in SICS like 2 mm incision surgery, smart incision surgery. With customization of incisions, the astigmatism can be managed very well. SICS has become a premier surgery now. The International Society of Manual Small Incision Cataract Surgery was launched in 2005 in Mumbai. Dr. Amulya Sahu is the founder chairman of the organization and Dr. Jagannath Boramani is the executive chairman of the organization. The first international conference of ISMSICS was organized in 2005 in Beijing, China. The second international conference was held in Malaysia in 2007. This was a 3 days event with wet lab, live surgeries, and scientific deliberations. This was followed by successful conferences in Indonesia, Sweden, Egypt, Philippines, and South Africa. ISMSICS surgeons were invited to conduct wet lab in Asia Pacific Association of Cataract and Refractive Surgeons Conference in Kuala Lumpur in 2015. Dr. Bormani, as the first editor, published many journals of the organization in the past. The organization started holding World Conference every 2 years. The first Comprehensive Cataract Conference, CCC 2015, was held in Pune. The Aravind Eye Care System organized the second CCC in 2017, in Chennai. This conference witnessed the joining of Help Me See with ISMSICS for simulator-based training. An instruction course as well as wet lab were conducted in WOC 2018 in Barcelona. The ebook, Master's Guideline on SICS, was released during this conference. The organization has arranged multiple programs in partnership with various associations. The World Conference CCC 2019 was a 3 days grand scientific fiesta in Kolkata. The All India Ophthalmological Society started giving ISMSICS 2 big sessions in every annual conference since 2018. WOC 2020 also gave a session to SICS surgeons. ISMSICS has now chapters in almost all states of India and across many countries in the world. We have started training on SICS simulator in partnership with Help Me See. The internet-based global SICS training program was launched during AIOC 2022. ISMSICS started the publication of journal again in 2022. After the physical launching in Egypt and Bangladesh, during the pandemic, chapters were launched in almost 15 countries. The COVID pandemic witnessed almost 50 webinars with massive attendance. ISMSICS has got a women's wing to address specific issues of women surgeons. The Emeritus Society of Ophthalmology organized a 2 days hands-on training workshop in Dubai in June 2022. The Australia and New Zealand chapter was launched during the annual conference of the Royal Australia and New Zealand College of Ophthalmologists in October 2022. The fourth CCC was organized by PGIMER, Chandigarh, in November 2022. In February 2023, ISMSICS conducted workshops and sessions in Emeritus Society of Ophthalmology Conference at Abu Dhabi. The UAE chapter also was launched. In 2023, chapters were launched in Singapore and in Nepal. ISMSICS was also invited for a study tour in Vietnam. In October 2023, ISMSICS was given a session and a live surgery in Annual Russian Ophthalmic Congress. Dr. Boris Malyagin announced the formation of Russian chapter of ISMSICS. These are the forthcoming events of ISMSICS. The 5th CCC will be held in Hyderabad in 2023.
Yeah, thank you very much. So this was the journey of ISMSICS, and we expect some program in Cameroon also in near future. Thank you very much.
Thank you so much, sir. So we have Dr. Parishit Gogte sir, who is founder of Dr. Gogte's Eye Clinic in Pune. He is vice chairman of ISMSICS. Then we have Dr. Barun Nayak sir, who is consultant ophthalmologist, head of Department of Ophthalmology at Hinduja Hospital in Mumbai. He is editor-in-chief of Global Journal of Cataract Surgery and Research in Ophthalmology, which is the journal of ISMSICS. He's the current president of ISMSICS. Dr. Satanshu Mathur sir is Chief National Coordinator. He practices in Uttarakhand. Dr. Deepak Mishra is Secretary of ISMSICS. And myself, Dr. Aarti, I am the National Coordinator for ISMSICS. So moderating this session with me will be Dr. Neeta Dodwad ma'am, who is Medical Director at Brahma Netralaya and Guruneet Welfare Foundation in Mumbai. She is Joint Secretary of Women's Wing of ISMSICS. Over to you, Neeta ma'am.
Thank you so much, Aarti. Good evening, everyone, and welcome for this installation of Cameroon chapter. So, chairing this session, we have with us Dr. Amulya Sahu sir, Dr. Goramani sir, Dr. Brain. Since he has some emergency work, he is not able to join with us, or he may join shortly. And with us, we have Dr. John Cropsey, who is the Director of Clinical Training and Global Ophthalmology at Rwanda International Institute of Ophthalmology since September 2022. He's done his undergraduate and medical degrees from University of Michigan. He completed his residency at Wills Eye Hospital in Philadelphia, where he was a co-chief resident. For the past decade, Dr. John has been working with a team of doctors and other professionals to develop Hope Africa University's teaching hospital at Kibiyo, Burundi. Its first department of ophthalmology. Dr. John was inaugural American Academy of Artemis Award and was recognized by Michigan Medicine Alumni Society with Distinguished Humanitarian Award in 2018. We welcome you, Dr. John. Next.
Dr. John, you are around? So he'll be joining us shortly, then we'll ask him to speak now.
Okay. Welcome, Dr. Anik. So we have a chairperson for this webinar. Dr. Anik, she was born in Democratic Republic of Congo. She completed her studies in ophthalmology with distinction at Faculty of Medicine of the University of Kiansa. After settling in Canada with family, Dr. Anik resumed her medical studies at University of Montreal and met with greater distinction the Canadian requirement for a practice of medicine and more especially ophthalmology. She then completed her training with a postdoctoral fellowship in uveitis at McGill University. She is certified in ophthalmology by Royal College of Physicians and Surgeons of Canada. In addition to being a fellow of American Academy of Ophthalmology, Dr. Anik is a fellow of Royal College of Physicians and Surgeons of Canada, a fellow of Canadian Ophthalmological Society and fellow of College of Physicians of Quebec. Based in Kiansa in the DRC since 2019, Dr. Anik is the founder and president of Clinic de Ophthalmologie V Beyond MD and V Beyond MD Foundation. We welcome you, Dr. Anik. Would you like to say a few words here?
Yeah, thank you very much. Thank you for everybody for inviting me. Thank you, Harti. Yeah, as you said, that's all I can say, and I'm just feel privileged to participate to this conference and the installation of the chapter of Cameroon. I think that Africa really needs your help and to be together, the unit to make change in our country. This is one of the biggest country in the world because of the population. I know you in India are the biggest, but the Africa is going on, and we need more physicians who can do surgeries. And thank you very much for the opportunity that you give to Africa. We also have a chapter in Congo that you settled during the COVID, and we know that there is a lot of things to do, and we are not discouraged to do that. We will continue and help our people to do that. And I also I'm really happy to see John on this meeting, because I know him for long time, 2008, and we were residents at that time, and I will be happy to see him also. Thank you very much to all the chairman and the staff. Thank you so much.
Thank you so much, Dr. Anik. Sorry, ma'am. Dr. Anik has been part of ISMSICS for a few years now. She has been to India last year to attend the annual conference. And we are fortunate to have her here again in month of November to share her experience with us. Thank you so much, Dr. Anik, for joining us. Ma'am, you can continue.
Okay, thank you.
Yeah. Now, next chairperson for this webinar is Dr. Anil Shah. He is a private practitioner at Nandurbar, India since 1986. He is an innovator and a prolific cataract surgeon. He has won many awards for the snares for MSICS, large foldable IOL for MSICS, and he has got a Best Research Private Practitioner Award. We welcome you, sir, for this webinar. Would you like to say a few words here?
Yeah. Thank you very much. I will share my screen.
Sir, voice is not playing.
Voice is not there?
No.
Okay, can you hear me?
Yes, sir.
Good evening, everybody. I'm really very much thankful for inviting me on this occasion. Today we are launching Cameroon installation ceremony. In this ceremony, we are doing all the small incision cataract surgery, and we are spreading the knowledge of small incision cataract surgery all over. It is my sincere request to the members of Cameroon Society that they should initiate this initiative of small incision cataract surgery in their country. When we see that we are doing paper surgery, we get a complicated situation, and in that case, SICS can be a bailout package to our cataract surgery. So small incision cataract surgery must be spread all over the world, and Cameroon should take the initiative. I am really very much thankful for inviting me on this occasion. I welcome all the Cameroon members and office bearers on this occasion. Thank you.
Thank you, sir. Arti, can we start with the installation ceremony?
Yes, sure. So the most awaited event of the session, the installation ceremony. So I'm glad to say that Cameroon is our 23rd international chapter, and today we start with the installation ceremony. So first, we have with us Dr. Manga, who is a senior consultant ophthalmologist, practices in ISMSICS Eye Clinic in Douala. I invite Dr. Sahu sir to please install Dr. Manga as chairman of ISMSICS Cameroon chapter. Sahu sir is there? Yeah. Dr. Manga, would you like to say a few words?
I welcome Dr. Manga as the chairman of Cameroon ISMSICS chapter. Welcome, Dr. Manga.
Thank you, Dr. Amulia Sahu. Thank you very much. This is really a great day for Cameroon ophthalmology, because we have been struggling for the training of the cataract. So you have many cataracts here. Cataract is a curable blindness, but we have real problems to deal with it in this country because of the lack of surgeons and lack of affordability for the patients, and we are putting too much expectations on this partnership with ISMSICS. So we are very, very happy. This is a great day for Cameroon Society of Ophthalmology. This is a great day for Cameroonians, and we hope by I'm the president of Cameroon Society of Ophthalmology, and my wish is that in 2 years, maybe we could have 20 good trained cataract surgeons. 20 is not too much, but if you have 20 more, that would be great for us. So thank you very much for allowing us to be part of this excellent network for training, and thank you so much.
Thank you.
Yeah, Dr. Manga, I think you are a leader, and you have a very clear sight, and we are there to support you and train your people to become better surgeons. I really appreciate your involvement.
Thank you, sir. Thank you.
So next we have with us Dr. Bilong Yannick, who is ophthalmologist, associate professor, SICS and a phaco surgeon who practices at University of Yaoundé in Balmayo. So please forgive me if in case I mispronounce anybody's name. Since the names are new, I really had a good session with Dr. Steve so that I can pronounce it very well. Dr. Bilong is actually, I should thank him. He is the man behind the Cameroon chapter. He has taken so much of efforts. We were in touch for last 3 to 4 months, and I'm happy that today this is happening. So I invite Dr. Boramani sir to please install Dr. Yannick as Secretary and Scientific Committee member of Cameroon chapter of ISMSICS.
Yeah. Welcome, Dr. Bilong. I announce that Dr. Bilong Yannick is installed today as Secretary and the Scientific Committee member of the Cameroon chapter of ISMSICS. So under yours and Dr. Manga's leadership, I think this chapter will do very well as far as the SICS training is concerned. Thank you very much.
Dr. Bilong, would you like to say something?
Oh, not especially. I am too happy to see everything that is the beginning of some things. I think we have to share our knowledge and also help the patients. So I'm very glad to be here, and also happy to what I can see in the future. I think we can do more things. So thank you very much. Thank you.
Thank you so much. Next, Dr. Andre, who is ophthalmologist and a professor, a prolific SICS surgeon who practices at he practices at University of Yaoundé. He is also the National Eye Health Program Coordinator for Cameroon. So I invite Dr. Karamjit Singh sir to please install Dr. Andre as Scientific Committee President of ISMSICS Cameroon chapter.
I welcome Dr. Andre as Chairman of Scientific Committee of Cameroon chapter of ISMSICS. I think under his able guidance, the Cameroon chapter will have some fantastic scientific programs in future. And the Cameroon chapter will gain on new heights under the able guidance of all the office bearers of ISMSICS. I wish good luck to Dr. Andre. Thank you.
So Dr. Andre is around?
No, he's not here. He will join us later because he have an appointment with in the ministry. But if he join us, we can give him the talk.
Yeah. So I remember you mentioned that he'll be talking to us. So I thought I'll invite him. No worries at all.
Okay.
So next we have Dr. Elizabeth, who is ophthalmologist, a practicing SICS surgeon at Yaoundé. She is the executive committee chairman of ISMSICS Cameroon chapter. I invite Dr. Anil Shah sir to please install Dr. Elizabeth as chairman of executive committee.
Welcome, Dr. Elizabeth. I, Dr. Anil Shah, as the president of Maharashtra chapter and also a member of International Society of Small and Cataract Surgery, invite you as an executive committee president. I hope you are one of the good SICS surgeon and you will be training all the PG students and also other colleagues in small and cataract surgery and will definitely spread the knowledge of small and cataract surgery all over the country. I welcome you on this behalf. Thank you very much.
So Dr. Elizabeth is here. Okay, so we move on to the, yeah.
Okay, no, I don't think she will not. Let's just go ahead.
Fine. So we have next Dr. Godfrey, who is practicing ophthalmologist and associate professor, SICS surgeon at Military Hospital in University of Yaoundé. He is the scientific committee member. So I invite Dr. Boramani sir to please install Dr. Godfrey as scientific committee member.
Yeah, I announce that Dr. Godfrey is installed as scientific committee member of Cameroon chapter of ISMSICS. Thank you.
Is he around?
No, sorry, it's not.
Okay, fine.
Aarti, you are muted.
Neeta ma'am, would you like to take over from here?
Yeah, thanks, Aarti. Dr. Cameron Gills, who is an ophthalmology professor and SICS PECO surgeon at Yaoundé Central Teaching Hospital. We welcome you, sir, and I request Dr. Boramani, sir, to announce Dr. Cameron Gills as a scientific committee member.
Yeah, Kagme, thank you very much. I announce that Dr. Kagme Gills is installed as the member of scientific committee. Thank you.
Yeah. Congratulations, Dr. Gills. Is Dr. Gills around? If he is not, we'll move to forward. Dr. Vayala, who is an ophthalmologist, associate professor and SICS surgeon at Yaoundé University. I welcome Dr. Vayala and I ask Dr. Sahu sir to induct Dr. Vayala as a scientific committee member. Scientific committee member, Dr. Vayala, are you around here? You would like to say a few words? Okay, I think she's not there. We'll move. Dr. Ivana Steve. So we have had a conversation with him just before the seminar, and he helped us to pronounce. Hope we are doing it in a proper way. Welcome, Dr. Ivana Steve. He's an associate professor. He's a SICS surgeon at Douala University of Yaoundé. Welcome, and I request Dr. Boramani sir to induct Dr. Steve as a scientific committee member.
Yeah, welcome Dr. Ibana Steve as the member of scientific committee. Thank you.
Thank you, sir.
So you would like to say a few things, Dr. Steve?
Oh, no, thank you. I will have to talk later, so.
Yeah.
So no problem.
No problem. We look forward for your contribution to this webinar and to this society. Next, we have Dr. Ted, who is a SICS and PECO surgeon, pediatric ophthalmologist at Margrabi Eye Institute, Okala. Welcome, and I request Dr. Boramani sir to induct Dr. Ted as a scientific committee member.
Yeah, welcome Dr. Ted as a scientific committee member. Thank you.
Dr. Ted, are you around here? Fine. Aarti will move forward. Dr. Kunz, ophthalmologist at Laquentin Hospital, Douala. I request Dr. Anil Shah to announce executive committee member of Dr. Kunz.
I invite Dr. Mosavi as an executive committee for this webinar, and as a Cameroon scientific member for this executive committee, I invite him as an in this committee as an executive committee member. Thank you.
Thank you, sir. We move forward to next executive committee member, Dr. Gianni. She is here. She is a pediatric ophthalmologist at Lafontaine Hospital, Douala. So I request again Dr. Shah sir to induct Dr. Jan as the executive committee member.
Dr. Mehanuji, I didn't spell properly, but I invite her as an executive committee member for this Cameroon conference webinar. Thank you very much.
Dr. Jain, would you like to say something?
Yes, thank you. Thank you, Dr. Shah. Thank you, everyone. Thank you to the ISMSICS chapter. I'm very proud and honored to be part of this. You know, this is my dream coming through because I discovered the ISMSICS about 4 months ago when I was going through a hospital-based training program for M6 in my hospital, and I saw that there were so many resources on your website. And I was like, when are we going to have a chapter in Cameroon? Only a few months later, the dream is coming through, and I'm very thankful to Dr. Manga for this opportunity. And I'm also very privileged. I feel privileged to be part of the chapter in Cameroon. I hope that we are going to make the best out of this opportunity to train more surgeons in Cameroon. I'm a very fresh M6 surgeon, and I'm also very glad to see that there is a women wings because as a matter of cataract surgery and training, women have particular conditions, making their practice of surgery very, very special. So I'm so happy that all those different aspects are taken into account. And I don't want to take the talk for too long, but I have 2 questions because I've been writing many emails to the scientific secretary and I never had any answer. So I want to take this opportunity to ask my questions. The first one is about the global M6 program online. I've never been able to go through that link and have more on it. And the second thing is that I'm really longing to attend the CCC conference in November in Hyderabad. And I've not been able to make my registration. I've tried so many times to no avail. So I wanted to take this opportunity to ask those 2 questions, and I hope that I will have some satisfying answers by then.
So, Dr. Boramani, would you like to?
Thank you.
Yeah.
Arti, you can give her contact number to Vaidehi regarding the registration. She'll manage. She'll communicate through WhatsApp and manage. Okay. As far as I think she has asked about the global SICS training program, this will be relaunched now in Hyderabad conference.
Okay. Okay. Thank you.
Yeah, thank you.
And you must give a CC to Jagannath.
Sure, sir.
Okay.
So next we have Dr. George, who is a ophthalmologist at Les Caesarea Eye Clinic, Douala. So I request Dr. Sahu sir to induct him as an executive committee member. Dr. George.
I couldn't hear you. Can you repeat?
Dr. George sir, as executive committee member.
Yeah. Okay.
Welcome.
Welcome, Dr. George.
Yes.
Okay. Want to see you more active in this platform and be in touch with us. Welcome to ISMSICS.
Dr. George is around here. Next, we have Dr. Christian, who is a SICS surgeon at Douala International Eye Care Center. I request Dr. Boramani sir to induct Dr. Christian as a scientific committee member.
Yeah, I announced that Dr. Christian is installed as member of scientific committee. Thank you.
Thank you, sir. Next, we have Dr. Neena, who's an ophthalmologist at Idia Regional Annex Hospital. So I request Dr. Aarti to induct Dr. Neena as a scientific committee member.
I welcome you, Dr. Neena, as scientific committee member and looking forward to work with you. Congratulations.
Thank you. Neena, are you here in Neena? It's good to see many females here, so we can have a women's chapter in Cameroon too. So next we have a Dr. Carrie with us. She's an ophthalmologist from Jawla General Hospital. So I request Dr. Boramani sir to induct Dr. Carrie as a scientific committee member.
Yeah, welcome Dr. Carey as the member of scientific committee. Thank you.
Dr. Carrie, are you around? So congratulations to all the office bearers of a Cameroon ISMSICS chapter. We look forward for your good contribution for learning of this MSICS and lot of innovation and research work. So over to you, Dr. Aarti, for the today's speakers.
Yeah. Congratulations once again, and we look forward to a productive Cameroon chapter of ISMSICS. So let's move on to the second part of the.
Dr. Parikshit Gopte is joined. Would you like to speak something, sir? He just joined now.
Yeah. So okay. Looks like he's on mute. So we will move on to the second part of the evening, which is the academic discussion. So I would like to invite Dr. Karamjit Singh sir for his presentation. So let me quickly introduce you all to Dr. Karamjit. He is professor at RIO Government Medical College in Amritsar in India. He is medical superintendent at Government Medical College in Amritsar. He is honorary secretary of Punjab Ophthalmological Society. He is joint secretary of North Zone Ophthalmological Society. He is president of Punjab chapter of ISMSICS. He is member of academic committee of Health University in Punjab. He has around 14 research projects under him currently, and he has various publications in national and international journals. He has received gold medal from Government of Orissa for his community work. He holds special interest in cataract, pediatric ophthalmology, and strabismus. Over to you, Dr. Karamjit Singh, sir, for your presentation. His topic of discussion will be basics of MSICS.
Thank you, Dr. Aarti. So I'm sharing my screen. So good evening and thanks the ISMSICS for giving me opportunity to speak on the basics of SICS, and I welcome all the members of Cameroon chapter to ISMSICS family. So I have no financial interest in this talk. So why MSICS?
Sorry for the interruption. Your slides are not moving, and can we put it on a slideshow mode?
It is on slideshow mode, I think.
It's not seen. I think, Neeta ma'am, it's the same for you.
Let me check.
Can you stop the screen share and share it once again?
Just down there is a.
So now
these
are visible.
Yes. Now you make yes.
Yes.
So you can put it on a slideshow mode, please.
It is on slideshow mode now. From my side, it is on slideshow mode.
Sir, I think the screen which you're sharing is of your main this thing. It's not a slideshow window. So you'll have to share your slideshow window separately.
It is not on a slideshow.
Yes, I am correcting it.
I'm leaving. Take care of.
I'm sharing again.
So you can put it on slideshow mode and then share.
Okay.
And share it with the video enabled, optimized for video.
Meanwhile, Aarti, we'll wait for 2 minutes, and otherwise we'll take till he prepares for the slideshow. You can take the other.
Yes, ma'am.
Just okay.
Sir, can I request you to share your presentation with me on email, and I'll run it from my end if yours doesn't work. We can try once from your end.
Okay, I'm. So I don't know what is the problem.
Sir, when you click share screen, you'll get an option of all the windows that are open on your desktop. So you choose the one with the slideshow window, not the one which is the PowerPoint presentation window.
Aarti, can you take the control and do something?
Yes, sir. Sure, I'll do, sir. Sir, we'll sort it out. Till that time, I would like to invite Dr. Ibana Steve for his presentation. We have introduced him, and he is the scientific committee member of Cameroon chapter of ISMSICS. He's going to talk to us about cataract surgery. Where are we today in Cameroon? So, Dr. Ibana, you can share your screen.
Okay, thank you, Dr. Arti. Is it okay?
Yes, you can go slideshow. Yes. Yes.
Okay.
Yes.
Okay, thank you for giving me the floor. I'm just very honored to, on behalf of all the committee of Cameroonian Society of Ophthalmology, to give some few words about cataract surgery. Where are we today in Cameroon? So we will be going to this topic, respecting this plan. First of all, introduction, giving some subject about outcomes, insisting on our different challenges before giving a conclusion. So I will not come back. I'm hope all people know there the challenge that blindness represent for all the public health system, with 33.6 million adults for more than 50 years in 2020 around the world. Then cataract remain the leading cause of blindness. So cataract surgery rates is still the problem. In Africa, we are around 5,000 per million per year, 500 million per year. This is low than the target, which is around 2,000 per million per year cataract to achieve. Then what about Cameroon? I hope everybody's seeing these are a beautiful country that we love so much. Cameroon, just here, is just like a triangle. We are near from the Nigeria, the central part of Africa, just above Gabon and Congo. And then in the east part, there is Chad upper, and down is Central Africa Republic. So, though from the World Bank 2 years back, we were around 27.2 millions of Cameroonians. It's not that huge as in India. With a prevalence in this study, in this outcome study, of cataract around 5 0.14%. Then cataract is still in our country the first cause of blindness. This study made some years ago, first cause of bilateral blindness. And I think you introduced Professor Ibale, who is the secretary of this national eye healthcare program in our country. And then also we are with Dr. Manga, who is the president of the Cameroonian Society of Ophthalmology. In our public system, in our system, health system, there is two systems working together. There is the public health system, and then most of the hospital too are working for the private one. So in Cameroon, there is the need of surgery is 48,000 surgery needed per year for cataract, and with a backlog of 115,000 people for surgery needs each year. So you can see the gap. And then our CSA cataract surgery rate is around 748 surgery per million per year. We are still too low, half too low for the surgery target rate. So what are the techniques that we are using in Cameroon? There is a large incision extracapsular cataract surgery, which is still done in some place, in regional place. Now the gold standard in our country is manual surgery, small incision cataract surgery. And now there is increasing surgeon in case of aqueous-emulsification. Seems most of the people in big towns are asking for this technique. So the outcome, this is the outcome here. We just have this study for the SICS. As you can see, we are still small. Our results are just below 80%. But anyway, in littoral, there are some stages. All these studies some years ago were 76 or 75 of the best corrected visual acuity after surgery, which is not bad. And then this last study was done with uncorrected one. So what are the main complications that we have in our place? Is intraoperative, is posterior capsule ruptures that we have in surgery here. And in post-operative, I list the most common, transient intraocular pressure elevation. We have some case of corneal edema, can be transient or become chronic also. And the other complications who are less, but we still see them, we have them, less decentration, iris capture, and some few cases of ephema. And then I was looking through our literature here, very, very few cases of ophthalmitis. So what's our challenge? I take this slide from this very nice study done by the team of ICO Maghrabi with Dr. Henri Kumbe. Our the barriers that we have here, first is the cost of surgery. The surgery, since most of the Cameroonians don't have any insurance policy, they have to afford for surgery by themselves. And all of this population are people out of the working, most of all on retirement or are staying in the region, the rural part of the country. The fear of surgery is still there because many people who have problems will go on community place, and then discourage the other people to come and join the surgery program. Then you have the traditional medicine, who is also have a lot of patients who are believing in them. Lack of awareness is still there. No perceived need sometimes, negligence, belief and superstitions. Some hospital reputation, this is going less. Lack of escort, because if somebody is blind, you don't have anybody to bring him. And then you also have this distance from the place where the patient lives inside the community and the surgical centers. So you can go to this and see what we have to challenge here. So in these cataract surgery centers, when the patient is almost there, I almost talked about the cost of the surgery. It can be difficult tough for the patients. Lack of cataract surgeon, most of all in rural centers, because around 60% of ophthalmologists are just in the capital of region, are in the big towns. So sometimes there is some also lack of, let's say, motivation, and then sometimes this problem of training. Lack of surgical equipment, because we have to face many challenges. There is many programs here to fight against malaria and so on. So sometimes some center can need, but they will not, depending on the budget that they have, cannot buy a good microscope to do cataract surgery. So lack of access to surgical consumables is a huge problem here. I saw that in India and most of the other countries, they can almost produce the consumables that they are using. Here we have to buy everything from everything is coming out of the country. So let's cataract surgical outreach perform. Instead, in public centers, we have to organize it. Sometimes budget and motivation and even the comprehension of some top management are not, they will not understand why will we use all this money, so let the patient come in the hospital. So, like Dr. Manga said previously, we have to increase our numbers of trainers. Here we have some of the first people to do SICS here, and some phaco surgeons were trained in India, like me, like most of Professor belong in China and so on. So they have to come, when coming back, and started to help also for the training of most of our residents who are posting here. For phaco surgeon, some have been trained in India, some few in East Africa too, and then some in some country of Europe. So two formal local training centers here. The center organized in the Faculty of Medicine. We are some of the lecturers are here also in this meeting. Professor Viola, Professor Bilon, Professor Koki, and so on. And then the resident will go through all this posting when they are going through the graduation to learn the skills, to learn about SICS and the other surgeon. And then I think Maghrabi ICO, OWB, and OB sometimes we can give some exposure also to the trainers, to the trainees. So phaco emulsification. What about phaco emulsification? We have some increasing demand of phaco in our cities. Is becoming popular in some people of high society, intellectuals. People like it, they call it laser surgery, and then most of the people have to sometimes even go out of the country to do it. And then the cost is still high, around 1,000 and 2,000 US dollars per year. Is some challenging if you don't have money. And then it's almost done in private center. I think just one public center try it, but I don't know if they will go on because of the problem of consumables, and then sometimes also maintenance of phaco machines. And also you can go and do the training, but your assistant, sometimes the team, there is lack of trained people, and then there is so many challenges to have if you try to hold this surgery in the public area. So, like I was saying, I have some 5 minutes to undergo for this presentation, and then now the conclusion. Just to retain that cataract surgery in Cameroon is effective, even though you have to give a really uptake to have a proper cataract surgery rate. The cataract surgery gold standard is the techniques is SICS. And then maybe we need to improve our strategy. That's why we are going on, looking at all this good cooperation, and some people who are maybe have a better organization to help us improve and increase the number of surgeons in our place. I'm thanking you for your attention.
Yours is an excellent presentation.
Thank you so much, Dr. Steve. You gave us a very good idea about what happens in Cameroon when we talk about cataract surgery. I have a question for you. If I may ask you, how many ophthalmologists are there in Cameroon?
Last numbers, I'm sure Dr. Manga will give us, but we are more than maybe 120.
Around 150.
And 50, okay. Thank you, Dr. Manga. So maybe 30%, around 30% are well-trained and are good surgeons, and most of these surgeons are just in 2 or 3 towns in the country.
Okay. So we have with us Dr. John, who is actually in a regional institute in Kigali, which is a beautiful city in Rwanda. Dr. John was watching us on YouTube, and I'm fortunate that he is back here. So, Dr. John, would you like to tell us about something about Rwanda when it comes to cataract surgery?
Hi, greetings from Rwanda, everybody. Yeah, I think something that's been really interesting in Rwanda with cataract surgery is that the Ministry of Health has partnered with different NGOs to establish cataract capacity in the 40 plus district hospitals. And then each ophthalmologist adopts a hospital, or actually 3 per ophthalmologist. And when the ophthalmic clinical officer has a caseload of about 50 to 100 cases, they call the ophthalmologist to the district hospital, and we do the cataract surgeries in the district hospitals to make it easy for the patients. And so that's been a fantastic way to have a patient-centered ISMSICS program sponsored through the Ministry of Health in partnership with Fred Hallows Foundation and others. So that's been an interesting thing to see develop here in Rwanda.
Yeah. Neeta ma'am?
Yes.
Do you have any questions here?
Dr. Kamarjit Singh, is he ready with the presentation?
Yeah. Ma'am, can I just ask a question?
Yes, sir.
Sure, Parikshit sir. Sure.
No, I had wanted to ask the Cameroonian ophthalmologist. I was in Cameroon about 10 years ago in Yaoundé for a week. So there, that time they would do SICS and some phaco. So is it that even outside Yaoundé and Douala, the 2 major cities, there is still a lot of cataract surgery on phaco being done, or it's still all SI?
Dr. Manga, would you like to answer that?
As Dr. Steve said, we have manual SICS, which is the most practiced. But if more and more phaco are done, especially in private clinics, and people are asking for more phaco because as he said, people ask for, are you doing laser? Are you doing laser? so laser means phaco. So more and more patients are asking for laser surgery, but what is done in most hospitals now is manual SICS.
Thank
you, sir.
So, if Dr. Karamjit Singh, if you are ready with the presentation, please start sharing.
Yes, I am ready.
Yes.
So now,
yes.
Is it in the PPT mode?
Yes.
So we are good to start now.
Yes, thank you very much. And sorry for some technical delay. Basically, my talk is on basics of SICS. So I have no financial interest. So we all know that cataract surgery rate has been around a credible 6,000 per million population in the world. But the coverage is variably across the geographic and demography with sharp urban-rural divide. So cataract surgery these days demand early visual recovery and near normal vision. This can only be achieved with phacoemulsification and MSICS. Phaco being the costlier procedure and less availability, so MSICS is a wonderful option for patients in rural and semi-urban areas, especially in developing countries. So this is about something why MSICS is preferred in developing countries, because the surgical results are comparable to phacoemulsification, and less costly equipments are needed, and it is less time consuming, and also the learning curve of SICS is comparatively low as compared to phacoemulsification, and fewer complications in complex cases. So MSICS is still the surgery of choice in high volume cataract settings, developing and underdeveloped countries, and some complex cataract cases. And there are many modifications that has been described by many of the authors. And these days, the 2mm SICS, which is my preferred technique, which I learned from Dr. Sahu sir, which is a wonderful technique that I want to show you in the last of my slides. So these are the few of the indications of MSICS for the beginners. The nuclear sclerosis grade 2 to 3, it is very good for the beginners to try SICS in those cases, or when there is a posterior subcapsular cataract, then if there is cortical cataracts. So in all these, for the beginners, the other procedures like phacoemulsifications, so lots of complications can happen in these type of cases. And of course, experienced surgeons can do all type of cataracts, can handle all type of cataracts with MSICS. So these are the few contraindications, but in my experience, or if the surgeon is experienced, there is no contraindication for MSICS. So no special equipment is required. Instruments used for routine cataract surgery can be used for MSICS with the addition of 1 or 2 instruments. Technique is simple, very simple. I will show you in the video that the technique is, we all know that technique is very simple as compared to phacoemulsifications. These are the few steps of the you can say MSICS or SICS. The complications, although complications are less, but there are complications with every surgery. So these are the few complications intraoperative, like wound related complications and incision related complications. Then the descemet membrane detachment, the conjunctival ballooning or paracentesis, or capsulorhexis related complications that happens during the nucleus prolapse or delivery from the corneoscleral tunnel, or hyphema, which is quite common in MSICS in the beginning, but with experienced surgeons, this can also be overcome. And post-operative, we can encounter wound leak, descemet membrane detachment, corneal edema, endothelial damage, uveitis, secondary glaucoma, or toxic anterior segment syndromes. And these are the few late complications which can happen to any cataract surgeon with any type of cataract surgery. These are the few late complications. So these are the complications which are unique to MSICS, the surgical induced necrotizing scleritis, which is although very rare, but it can be there. There can be buttonholing of the tunnel. There can be premature entry. There can be nucleus which is engaged in the tunnel. There can be cortex which remains in the anterior chamber with MSICS. There can be wound leak. There can be paracentesis leak. There can be exposed suture knots. If there is a need of application of 1 or 2 sutures in MSICS, or sometimes incorrect suture placements can be there. So the corneal complications, although they are more with the beginners, the corneal edema, descemet membrane detachment, striate keratopathy, pseudophakic bullous keratopathy, epithelial defects, or recurrent erosions. So these are the common corneal complications which can be seen more commonly in SICS as compared to phacoemulsification or the other techniques of cataract surgery. So my preferred technique is 2 mm MSICS with 2 mm incision with all advantages of phacoemulsification. So I'm sharing one of my initial videos, the technique which I learned from Sahu sir in Amritsar when Dr. Sahu visited our institute. So this is 2 mm MSICS. These days I'm doing this technique. So the first is making of the corneoscleral tunnel, which is 2 mm. So this is the tunnel making. This I learned from Dr. Sahu sir. So it is very easy. Even our residents are doing the cataract surgery with this technique with slightly grade 2 or grade 3 cataracts these days. So this is the tunnel making. So two mm tunnel, then the side incisions. So I am doing exactly Dr. Sahu sir is doing. Enlargement of side pockets. So this is how we enlarge the side pockets. Now the tunnel is complete. I'm a little bit fast forwarding it because of time constraints. So now making of side port, and after that capsular access from the side port. So completion of a little bit large capsular access. Then hydrodissection from the side port. Then entry into the anterior chamber. Then extension of the side ports towards nasal and temporal site. So you can see that the inner incision is a little bit bigger. Then this is the prolapse of the nucleus into the anterior chamber. And while prolapsing, so division of the nucleus into two and with wire vectors, simple wire vectors, the nucleus is expressed out. The remaining piece of the nucleus, it is also out. So you can see a red reflex, very good red reflex with some cortical matter. Even we can do polishing. Then implantation of intraocular lens. It is foldable lens basically. So this is the first case closure of the incisions. This is the second case. Corneoscleral tunnel making the same as previously done. Then the rhexis, slightly bigger rhexis. Then anterior chamber entry. After that, prolapse of the nucleus into anterior chamber. Then the second technique that I learned from Dr. Sahu is viscodissection. So first I put the vectis just behind the nucleus. Then with this cannula, the nucleus is divided into two. So this is slightly immature cataract with grade 2, nucleus grading 2. So this is the vectors which Dr. Sahu gifted me in Amritsar. So the foldable intraocular lens, hydrophilic, it is hydrophilic. We can implant any type of lens, whether it is hydrophilic or hydrophobic. So this is the end of the surgery. So SICS is a wonderful technique. With the 2 mm SICS, I think we can achieve the comparable results with phacoemulsification. So thank you very much for your patience listening. Thank you.
Thank you, Dr. Karamjit. That was an excellent surgical demonstration of 2 mm. Congratulations, you have learned well and demonstrated well. So panel is open for any questions for Dr. Karamjit.
I am thankful to Dr. Sahu. He specially came to our institution, visited our institution, and we organized one live surgical session over there where he taught us the 2 mm SICS. Thank you, Dr. Sahu. Thank you very much.
Yeah.
Kamaljit Singh, may I say something?
Yes, sir. Yes.
Yeah. Kamaljit Singh, congratulations. You have shown a very beautiful technique of 2 mm small incision cataract surgery.
Thank you, sir.
The main important thing is that why SICS and why not phaco? I say my journey started from Van Graff's knife to intracapsular, extracapsular, then SICS, and after that I learned phaco. But what happened that when I started doing phaco, I had 2 nucleus drops and 4 PC rent. I'm staying in a very poor area where I cannot afford my patient to have such complications. And if such complication occurs, I have to send them to 300 kilometers for VR surgery. And because of that, the patient was not paying and not able to go. They face the complication and they lose the eye. So then after that, I decided it is better to shift on my original technique of small incision cataract surgery by snare. And then after that, I started doing my snare technique. It is from 3.5 millimeter incision. and we are doing all premium type of lenses, all toric lenses, everything under 3 millimeter cataract surgery, 3 millimeter incision. And I hope that we are very safe when we do small lesion cataract surgery. FACO has given us complications which were not there in small lesion cataract surgery. In FACO, we get nucleus drop, corneal burn, but in small lesion cataract surgery, whatever the complications are there, eye can means our eye is so great that it can manage all the complications that patient can get good vision. We get complications like hyphema, iris prolapse, or these type of basic complications like corneal edema. But there are no major eye losing complications in small lesion cataract surgery. So I feel one should learn SICS as one of the best technique and equivalent to the phaco surgery. Thank you, Dr. Kamarjit Singh, once again for showing 2 millimeter incision surgery very nicely.
Thank you, sir. Thank you very much, sir.
Thank you so much, Karamjit sir. When we talk about SICS, the biggest disadvantage which has been proved by the literature is the induced astigmatism. And where the phaco stands better over SICS is astigmatism. So, Dr. Jagannath Boramani sir, you are practicing in the economic capital of country in India. So, wherein you do most of your cases are SICS, or should I say that you do only SICS and you are one of the very renowned surgeon in Mumbai. So what is your take on astigmatism when we talk about cataract surgery?
Yeah, first of all, let me clear that for last many years, now I have shifted to total SICS. If some patient forces me to do phacoemulsification, I will have that guilty feeling that I have done injustice to the patient, because I have wonderful technique of managing the pre-existing astigmatism. And I think most of you are also talking on my technique. Recently, I have presented it in Russia. So depending upon the pre-existing astigmatism, my wound position as well as the shape as well as the length varies, because many times we don't have all patients with a regular astigmatism, only temporal steep, and only can be tackled with a 2.8 or 3 mm incision. So we have to vary the incision, and accordingly you can combat the pre-existing astigmatism. So this wonderful opportunity SICS gives to you and not phaco. Otherwise, what happens, only with 0.75 astigmatism also, phaco surgeons immediately jump to the toric, because they said this has to be managed by toric, because their incision is fixed, corneal 1 and 2.8. SICS incisions are very forgiving type of incisions as far as the astigmatism is concerned, or even the infection is concerned. The wound is also well covered. So there are so many advantages of the SICS. So we are now promoting advanced SICS like this 2 mm SICS or the customized incision as an advanced surgery. And the surgeons are charging more than the phaco surgeons without spending on the equipment also. That is another economic advantage. But I want to ask Dr. Karamjit, what is your now average induced astigmatism with the 2 mm SICS?
Sir, it is very less. So
how much?
Average is 0.5 to 1 diopter average. So I start doing this 2 mm incision for last 6 months only. So my astigmatism is nearly 0.5, 0.75, and maximum is the 1, not more than that.
No, but if it is 0.5 to 1, then average becomes 0.75, which is as per reported with even a 6 mm regular front incision, isn't it? So I feel with 2 mm, you should get less astigmatism, because with a very more curved incision, even if I go up to 5 mm, I am not inducing any astigmatism, because the ends of the incisions are going away. I feel your incision should induce very less or minimally induce astigmatism. Second thing, do you position what is the position of your incision?
Sir, it is mostly superiorly, but now I am planning my incision according to the pre-existing astigmatism.
Because that should be done. Otherwise, because I feel your incision should not induce any astigmatism. 2 mm is hardly anything. That 2 mm, that too in a scleral incision. Maybe you compare your astigmatism with Dr. Sahu's astigmatism, and because surgeon-wise also variations are there.
Yes, sir.
And secondly, preferably it should be kept on the steep meridian. But if and you can use this only for the spherical corneas or having minimal astigmatism. Otherwise, you can very well negate the astigmatism like pre-existing 0.75, 0.1. Sometimes I take a straight incision of about 7.5 millimeter to neutralize a 2 mm 2 diopters of astigmatism. If in case of 2 diopters of astigmatism comes, you cannot do anything with the 2 mm astigmatism, isn't it? So that wound modification also has to be there. But it is very 2 mm SICS is very difficult to learn, and it is surprising that you are doing such a wonderful surgery. You have picked up all the doctor's house technique.
Yes,
and
yes.
in general, also SICS is not easy to learn. On the contrary, if you compare the learning stage of phaco surgeon as well as the learning stage of SICS surgery, SICS is more painful to learn. Especially in India now, in all the institutes, they teach the phacoemulsification. You have got so many videos on the YouTube, internet, and so many good teachers in phaco. So now on the new PGs, they learn phaco without creating much complications. You are in a teaching institute, you also must have experience. On the contrary, chances of creating complications in the learning stage are more. It is really painful one. To become a master in SICS takes a little longer time. And comparatively, the good SICS teachers are very less compared to good phaco teachers, isn't it?
Yes, sir.
Yeah. I asked in some PG teaching institutes where they give training in both the surgery techniques. They also say that the complications with the beginners are more in SICS than phaco. But our phaco masters, when they started learning phaco, they used to create a lot of complications because for them, experienced teachers were not there. They used to learn on their own.
The complications with MSICS are easily manageable.
Yes.
Easily manageable as compared to the phaco surgeons. We need VR surgeon.
Correct. So MSICS is in fact all. It is not only for developing countries, not only for urban, rural. It is for rich, poor, developing, developed, black, white, cataract, for everything. If you learn good MSICS, you can manage everything. On the contrary, I can always state the importance of SICS in other way around. In all the conferences, you hear the talks, how to convert to SICS in case of a complicated phaco. But you never hear a talk how to convert to phaco in case of complicated SICS. This means that SICS is for all.
Yes.
That is, yes, sir. Thank you. Yeah.
Yes,
Yeah.
sir.
Dr. John has raised his hand.
Yeah, those are wonderful tips. I think if we want to move SICS, advance it, we do have to pay a lot of attention to astigmatism, and maybe making these small wounds and snares is intimidating to some people. I would say if you look at most elderly patients, most people should be getting temporal M6 just with your standard M6. Just do your usual technique and sit temporally and make sure you close the conjunctiva. And most of the time that's going to be better than sitting superior because most elderly people have against the rule astigmatism, and operating temporally is going to reduce that against the rule astigmatism. So my rule of thumb, which I picked up from Tilganga, is if your steep meridian is temporal, it has to be sit temporal, and don't move superior unless it's more than 1 diopter steep or superior. You induce a lot more astigmatism sitting superiorly than you do temporally, because temporally you're further from the visual axis.
Yes.
So in Burundi, almost all of the surgeons have switched temporal because we saw how much better our results were with uncorrected visual acuity just by moving superior to temporal. And then you don't mess up the conjunctiva. In Africa, we have so much glaucoma. You don't want to disturb the superior conjunctiva if you don't need to. But the key is you have to close the conjunctiva nicely if you're going to go temporal. I just use a cautery and singe the conjunctiva together with forceps and cautery. No sutures. But sit temporal. If you've done over 100, 200 SICS superiorly and you're not getting a lot of complications with iris issues, switch temporally and try it. And then you don't have exposure issues either. You're not fighting the eyelid. You don't need a bridal suture. It's so nice. You'll never go back. Thanks.
Yeah. So we have a question from Dr. Bilong. How to choose the site of incision to reduce the astigmatism? So Dr. Boramani has answered it in the chat box. So you first determine what is the steep axis, and then you try to place your incision on the steep axis, keeping the center of the incision exactly on the steep meridian. Dr. Steve, you want to comment something?
Yes, thank you, Dr. Arti. Just to, because like we did our training in India, me, I was in Madurai. Then when I come back in the country, my observation was that our nucleus here was somehow bigger. So I have to sometimes increase the length of my incision. So I don't know when I'm looking at this technique, if you don't have a white cataract, you need to have 2 millimeters seems to be very, very small for the cataract that we have here. I don't know if there is anybody there who have operated, maybe Dr. John, compared to the eyes that we have here and then to the shape or the length of the nucleus. Sometimes you have to increase your length just 1 to 2 millimeter to have it all out and then put some sutures. It also good, but I'm just sharing the experience that I have here because from the beginning, just when coming back to India, I have some problem to pull things out. Do we have to cut it inside, to cut the nucleus inside before coming out? It seems to be very small, looking at the experience that we have here. Thank you.
Yeah, Anil sir, would you like to comment on that?
Yes, definitely. This temporal incision, which appears to be very easy for all of us, but the temporal incision has got many disadvantages. One disadvantage is that it can cause fish mouthing and lips of the wound can get open and the chances of infection are more common with the temporal incision. Another important thing is that post-operatively the patient's eye is also red and the patient feels that there is something done in the eye and because of that the eye is becoming very red. And also when the patient looks at the lateral side, he sees a blur image on the lateral side. That is another disadvantage. So I feel superior temporal incision, which is in between temporal and superior, is far better than temporal incision because superior temporal incision is covered by lead and it doesn't show any redness post-operatively. And superior temporal incision can cover also the all types of astigmatism. Main important thing regarding the astigmatism is that we can convert steep axis into flat, but we cannot convert flat axis into steep. So always our incision is on the steeper meridian, whatever the way you want to do. Then and then only we can flatten that steeper meridian and you can neutralize the incision. That I want to say regarding the incision and astigmatism. Thank you.
Thank you, Doctor. So, Aarti, should we move on to our next talk?
Yes.
Our next talk is on nucleus management in MSICS. I welcome Dr. Pranav Kadial. He is a good friend of mine. He works in a very beautiful seaside tribal area of Dhanu, Maharashtra. He is a prolific SICS surgeon practicing ophthalmology. Also loves writing and he is also a very good singer too. So with this short introduction, Dr. Pranav, please go ahead.
And I'm sure, Dr. Steve, you will get answer to your question in Dr. Pranav sir's talk when it comes to managing the large nucleus in SICS.
Unmute yourself, Dr. Pranav. Unmute yourself.
Now can you hear me properly? Can you hear me? Yeah.
Yes.
And are you able to see the slideshow? This thing?
Yes.
You are able to see. Okay. So before I begin, I would like to convey my heartfelt congratulations and best wishes to the newly appointed members of the Cameroon chapter of ISMSICS. I have no doubt that they will bring an MSICS revolution in their country. And I would like to thank Dr. Amulya Sahu sir for giving me this opportunity and the rest of the committee members as well to share my thoughts on nucleus management in MSICS. I have no financial interest. So first we have to remember the cardinal rule in MSICS, the management of the nucleus, to protect the two VIPs, the very important parts, corneal endothelium and posterior capsule. So regardless of the technique, it's very important to remember this rule. Management of nucleus begins with the prolapse of nucleus into the anterior chamber. A good hydrodissection will enable one of the poles of the nucleus to pop out of the capsular bag, as seen here. Then we can use one or two instruments and a tire iron technique to rotate the nucleus out into the anterior chamber. Is the video seen clearly?
Yes, it is seen.
Yeah. In rigid and or small pupils, you must use iris hooks or pupil expanders. Otherwise, it is also traumatic to the eye and traumatic to the surgeon as well. Nucleus delivery strategies include pushing the nucleus out of the eye and pulling the nucleus out of the eye. So regardless of whatever you use, the ultimate goal is to get the the nucleus out of the eye through a small incision in a safe manner. In pushing techniques, we create a positive pressure in the anterior chamber by infusing BSS or viscoelastic. Then we press the posterior lip of the incision and use additional instruments to guide the nucleus out. These are the most common techniques in use today. We'll be looking at them in some detail. In Blumenthal technique, we use an anterior chamber maintainer to provide hydrostatic pressure and a sheet slide inserted through the main incision to guide the nucleus out of the eye. You can also use an iris repositor for the same. In Ruiz technique, instead of an AC maintainer, we use an irrigating vectis. Some people also use a Simcoe's cannula. Endo expression, invented by Dr. Jagannath Boramani, is a very unique and interesting technique. In this, we use an AC maintainer to provide the hydrostatic pressure. We engage the nucleus in the main incision as shown. Then we enter the anterior chamber with a ISMSICS hook and gently push the nucleus out of the eye. I have seen surgeries being done through 4 mm incision using this technique. The ISMSICS hook can be used to cartwheel that nucleus out of the main incision, as shown. In viscoexpression, we inject viscoelastic through a cannula beneath the nucleus all the way to the other side, and that viscoelastic then pushes the nucleus out. My personal preference is to inject the viscoelastic through the side port and use a vectis in the main incision to guide the nucleus out. Pulling techniques are usually these two techniques which are in vogue, phaco sandwich and fish hook technique. Phaco sandwich is my preferred technique for most of my cataract surgeries. I use plenty of viscoelastic above and below the nucleus. Then I enter with an iris spatula above the nucleus and a vectis below it. I advance it to about 2/3 of its distance, grip the nucleus firmly, and then pull it out of the eye. A serrated vectis and ISMSICS hook will provide a better hold on the nucleus, and counter traction like a superior rectus suture or a forceps, and pressing the posterior lip of the incision helps to get the nucleus out easier. In the fish hook technique, we use a specially modified 30 gauge needle bent in the form of a fish hook as shown in the photograph. We enter with the fish hook facing sideways to avoid rupture of the posterior capsule, advance it almost to the lower pole, rotate it to hook the nucleus, and then drag it out of the eye. This technique is very popular in Nepal and some other countries. Sometimes you would want to break the nucleus down into smaller pieces so that we can remove them through a much smaller incision. In this, one technique is to engage the nucleus in the incision and then chip off the protruding part with a ISMSICS hook. Then we push the nucleus inside, reorient it with its narrow dimension pointing at the incision, and then remove it, using standard techniques of ISMSICS. We can also use the Akahoshi pre-chopper to crack the nucleus into 2 halves within the bag and then remove the 2 halves. Techniques in the anterior chamber include phaco fracture, where we use a vectis and a bisector or trisector nucleotome to crush the nucleus. But my favorite 2 techniques are the snare technique by Dr. Anil Shah and phaco section using a 26 gauge needle cystitome by Dr. M.S. Ravindra. In all these techniques, we must remember to use a lot of viscoelastic, especially heavy or cohesive viscoelastics. In the snare technique, I use an inexpensive snare designed by Dr. Anil Shah, as shown in the photograph. In this, we advance with a small loop diagonally through the incision, all the way to the end of the nucleus beneath it, then increase the size of the loop as we proceed, rotate it, and engage the widest meridian of the nucleus. Then we pull the snare closed. This bisects the nucleus. You can inject viscoelastic and then repeat the procedure to do a trisection of the nucleus and pull out the parts using a Kelman-McPherson forceps. As you can see, this hard cataract has been removed, is going to be removed through a 3.5 millimeter incision. Similarly, in the phacosection technique, a vectis is used to give support to the nucleus, while a 26-gauge cystitome is used to create grooves on the nucleus, deeper and deeper till it bisects the nucleus. The needle is attached to a viscoelastic syringe, and that is used to continuously infuse viscoelastic in the anterior chamber to maintain it. Then we can use that same vectis and cystitome to pull out those two halves. As shown by Dr. Singh earlier, Dr. Sahu's technique employs a version of this where he uses a cannula to bisect the nucleus. As we all know, a bowl of delicious endole, I hope I'm saying this correctly, can be made by using several excellent techniques. And all those excellent recipes are fine. So similarly, there is no perfect one-size-fits-all technique for nucleus management in MSICS. The technique must be tailored to the surgeon's preference and comfort level and the surgical situation. For example, the hardness and size of the nucleus, the associated ocular conditions. For example, a softer nucleus can be visco-expressed, but that causes an increase in the intraocular pressure. So you wouldn't want to use that technique in advanced glaucoma. Similarly, in smaller eyes, you would want to use a technique involving less instrumentation in the anterior chamber. Excuse me. Sometimes you can also use a combination of techniques. Whatever you use, you have to get the nucleus out safely. Beginners should start with larger incisions, use viscoelastic liberally. And once they are familiar with the basics, then they should upgrade to the more advanced techniques like snare and phacosection. Complications are due to faulty technique, instruments, and nuclear fragments. And this usually involves injury to the corneal endothelium, iris, and the posterior capsule with vitreous loss. These are all managed as per standard protocols. But that said, in MSICS, the complications are much less common and more forgiving than its more expensive celebrity sister, phacoemulsification. And I'm happy to say that in my 25 years of cataract surgery, I've never had even one case of nucleus drop with MSICS. So perhaps, as Dr. Boramani said, the MSICS should be the first technique and not as a backup to a phacoemulsification. Before I conclude, I leave you with a question to ponder. If you notice, we are all focused on mechanical and physical solutions to nucleus management. Are we looking in the wrong direction? Perhaps we should look at a chemical solution. So hopefully one day we will come up with a safe drug that we can inject intracamerally directly into the nucleus and dissolve it, and then simply suck it out using a Simcoe's cannula. That will ease the expense of surgery and it will make surgery go much faster as well. Thank you for your kind attention.
Thanks, Dr. Pranav. It was a good, informative answer and also some innovative ideas for a chemical nucleus management. So now the panel is open. If any questions are there, quickly we'll take few questions before ending the session.
I want to say something.
Yes, sir.
We must define SICS basically. When we are doing 7 millimeter, 8 millimeter, or more than 6 millimeter incision, then it should be called as a large incision cataract surgery. But when we do a 4 millimeter or less than 4 millimeter incision, then it should be called as a small incision cataract surgery. So all SICS surgeon must have a goal that they should reduce their size of incision close to 4 millimeter or 3.5 millimeter. And this is only possible when you do intraocular fragmentation of the nucleus. Because if you want to remove whole nucleus, then you definitely have to increase the size of the incision to 7 millimeter. And that is not actually ideal small incision cataract surgery. For ideal small incision cataract surgery, you should fragment the nucleus intraocularly. Though I don't want to say that snare is one of the best technique, but you try any other method in which you can divide the nucleus intraocularly and remove to the smaller incision, that will be a good aim. Our good aim towards the phacosurgery, means we are near to the phacosurgery. Second important thing I want to say that why we are attracted to phaco, because of the quick incision. We can do a quick incision of 2.8 millimeter and proceed for the surgery. And we are not confident in small incision cataract surgery because the incision takes more time and we have to struggle for the incision. So in that case, if we do incision which is similar shown by Dr. M.S. Ravindra, that we make a 2.8 millimeter incision and then extend it with a 5.2 millimeter, so that we get a fast incision and we can get a almost 5.2 millimeter incision, and our purpose is also served. So these two things I wanted to add, so that we can do a fast and quick SICS and less trouble in making the incision also. Thank you very much.
Thank you, sir, for your practical inputs. Dr. Boramani, sir, you want to say something?
SICS should not be basically called as small incision cataract surgery. It should be called as a sufficient incision cataract surgery.
And nowadays the incision is getting customized. It's no more small or a long. Yeah. It is the more of a customized incision.
So it can be a long also, it can be small also, it can be micro also. It should be sufficient as far as the nuclear size is concerned and the surgeon's technique is concerned. Yes. Small or big doesn't matter.
Yes. Anyone else has?
So we want to invite Dr. Andre. He has joined us. He was in another meeting. So he's the National Eye Health Program Coordinator for Cameroon. He wants to make few comments. Dr. Andre, you are there?
Prof. Somba. Prof. Somba, are you there? Hello?
We can hear you, Dr. Belong.
Yes. Can you hear us, Professor Somba? You can have
No, can't hear. I think I can see him, but I can't hear him.
Okay, no problem. I see him, but I don't know why he can respond.
So do you want to make him a call and tell that we are waiting for his comments?
Okay, I will do.
Yeah. So till the time, Neeta ma'am, we can take if anybody else has any comments.
So overall, we had a very good session today. We learned the situation in Cameroon about the cataract. We know the prevalence, what type of cataract surgery is been done there, and how much percentage of cataract is treated, and per patient the cataract surgeon. We saw a beautiful demonstration of 2 mm surgery by Dr. Karmarjit Singh, and also a very good practical inputs by Dr. Pranav Kodial on nucleus management. We have one small question in the chat box: how to calculate the toric length for 2 mm MSICS? So anybody, Dr. Boramani sir, would you like to take that?
No, it is specifically asked for 2 mm. Let Dr. Karamjit respond.
Yes.
I have no experience with putting the toric IOL in 2 mm MSICS, but as the previous speaker said that the 2 mm SICS can be planned in the steeper axis to minimize the pre-surgical astigmatism, or to control the pre-surgical astigmatism. Otherwise, as we all know that various toric calculators are available online and also offline by various companies, the J&J, even few of the Indian toric calculators are there. So we can calculate the toricity, I think, with some online calculators by putting the keratometric data in that.
Yeah.
Dr. Neeta, may I reply?
Yes, sir. Please, yeah, you can go ahead.
Yeah.
Yes.
So actually, I am just preparing a paper on this toric ion in SICS. When you are giving the toric ion, what is important is toric is SIA. That you have to mention, just like if FECO we mention 0.25 or 0.5 SIA, incision at 120 or 180. So in SICS, I always make my incision at 90 degree. You are talking about 12 meter, I am talking about general SICS surgery. So I always do SICS at the 90 degree. Suppose if I make incision of 5 millimeter incision, if I make a 6 millimeter incision, if I make a 4 millimeter incision, I know my estimate is SIA, what is going to happen. So if we know our SIA after opening 100 cases, so we know if SIA 5 millimeter incision at 90 degree is 1.25. So we add this 1.25 in SIA and we calculate the toric formula and we put IOL there. So when you are doing toric in SICS, it is beauty. You can make 6 millimeter incision, you can make 5 millimeter incision, you can make 4 millimeter incision because your SIA will compensate it. Your SIA will compensate it. So you can implant toric IOL very well, but you should know your SIA by giving incision at 90 degree or whatever place you give. You 4 millimeter, 5 millimeter, 6 millimeter. Boramani already has a detail about the incision size and the incision. So we have also calculated our incision accordingly. So that is the beauty of SICS. You can do hardest cataract, black and brown hardest cataract, toric. You can do the toric lens. We will soon publish the paper on this in journal, Indian Journal.
Basically, the principle for toric calculator is same. You have to use the software, toric calculator software, and whatever will be your induced astigmatism with that particular incision at that particular site, you have to feed in the software, and whatever the software gives you have to put accordingly.
You have to change two things only, SIA and the site of the incision, that's all.
Yes, that's all.
That you can calculate on your experience. So this is the beauty. In SICS also we can do toric now.
Correct.
Hope that has answered Dr. Anik's question. Is Dr. Andre online? Can we hear him now? Dr. Andre? Dr. Bilong, could you connect to him?
Yes, if when it's possible, he can join us. But I don't know what exactly, perhaps.
I think he's connected now to the audio. Let's see if he can speak and we can hear him.
Welcome, Dr. Andre. Please unmute yourself. Okay.
Dr. Andre, you are muted. Can you please accept the request to unmute yourself? I'm sending you the request. Please accept here.
Okay, no problem. Okay, you can go ahead. You can go ahead.
So good to have.
Okay. Okay.
Ça passe pas. Ça passe pas. Ça passe plus.
Oui. Oui, là où. Oui, on t'entend.
On s'entend là. Oui, mais moi, je veux plus suivre parce que je n'ai pas suivi. Je veux suivre les discussions.
Oui, oui.
I want to follow you, but I don't want to. I don't want to discuss because I didn't follow all the steps. So I just want to follow you. I just want to listen, but not to discuss a lot because I didn't follow the step of your surgery.
Sure. This meeting is being recorded, so we will share the link for the recorded session, and you can view that later.
Okay. Thank you.
Can I say something?
Yes, sir.
Dr. Pranav has said that there are two VIPs in the cataract surgery. One is endothelium, another is posterior capsule. But the third VIP is also there, that is iris.
Yeah.
If it is also damaged, then we can get a lot of complications. So there are 3 VIPs, and through these 3 VIPs, without touching anyone, we have to remove cataract. Thank you.
That is a practical input. Thank you so much. So any more questions? We are coming to the ending of this session now. So for vote of thanks, I thank all the office bearers of ISMSICS for to be present in this webinar. I congratulate and again thank all the office bearers, new office bearers of Cameroon ISMSICS chapter, and I will look forward for a good inputs from you all on the SICS surgery training and its research. And I also thank all the speakers for their excellent inputs and good SICS training surgery. So I thank Entour Pharmaceutical for supporting this webinar. So that's it. So good, and we'll communicate for any further updates through WhatsApp and online. So these webinars will continue and we'll update on that. And this channel is there on YouTube. If anyone has missed, definitely they can log in and watch the webinar again. So thank you so much, one and all. Good night.
Thank you.
Thank you, everyone.
Good night. Thank you, everyone.
Good night.
Thank you. Thank you very much.
Thank you, everyone, for.
Okay, thank you. Bye.
Thank you very much. Thank you.
Thank you, sir.
Thank you so much.